Good evening, friends. Warm welcome to you, and apologies for you the delay. I think both the invited faculty are still in the operating room. They will be joining shortly. I request Dr. Kirit and Dr. Srinivasan sir to conduct the day's clinics till the faculty come in. So, first case will be with the soft tissue tumor to be presented by Dr. Kritika. Kritika is kindly contributed by Professor Pabita ma'am from Government Tirunelveli Medical College. So, Kritika, please introduce yourself, your unit chief. Start your presentation. I think Dr. Karit and Dr. Srinivasan sir are quite senior faculty in our group, so they will be able to conduct the proceedings. Karit sir, please take over, sir.
Yes, sir.
Thank you, sir. Dr. Kritika, are you there?
Yes, sir.
Yeah.
I'm there.
Good luck to you, ma. All the best.
Thank you, sir. Good evening, respected faculties. I'm Dr. Kritika, postgraduate from Tirunelveli Medical College. Our HOD is respected Professor Dr. Babita Devi, madam. My unit chief is Dr. Rajkumar, sir. Today, I'm here to present a case on soft tissue swelling over thigh. Of history, a 44-year-old gentleman, Mr. Maharajan, construction worker by occupation from Thoothukudi, came to the hospital with chief complaints of swelling over the left thigh for the past 2 years. History of presenting illness, history of swelling over the left thigh, which was insidious in onset, initially the size of a gooseberry. No, the patient noticed the swelling while taking bath. The swelling gradually progressed over the 2 years to attain the present size. Swelling is not associated with pain. The patient was diagnosed as a case of carcinoma head of pancreas while evaluated for obstructive jaundice in Thoothukudi Medical College and has underwent ERCP stenting before 15 days at Tirunelveli Medical College Hospital. History of loss of weight and appetite present, 15 kgs in the past 2 months. No history of ulceration of the swelling. No history of restriction of limb movements. No history of paresthesia over left lower limb. No history of edema of the left lower limb. No history of fever. No history of trauma to left thigh. No history of radiation exposure or chemical exposure. No history of swelling elsewhere in the body. No history of cough or hemoptysis. No history of jaundice is present. The patient has history of pruritus, history of passing clay-colored stools, and history of passing high-colored urine. Past history, the patient is not a known case of diabetes, hypertension, or tuberculosis. Personal history, the patient is not a smoker or alcoholic. Family history, no history of similar illness among any other family members. To summarize my history, a 44-year-old male who is a known case of carcinoma head of pancreas with obstructive jaundice, now presented with complaints of swelling over the left thigh for the past 2 years, which is painless and progressive without any pressure effects. And the patient also has the features of obstructive loss of weight and appetite and symptoms of obstructive jaundice like jaundice, pruritus, clay-colored stools, and high-colored urine.
Please go to the first slide.
Sir?
Please go to the first slide.
Yes, sir.
Second slide. Okay. So how did the patient notice the swelling?
The patient noticed the swelling while taking bath 2 years back, sir.
So does the patient say that it was visible?
Yes, sir, it was visible.
Okay. And what about the any skin over the swelling? That patient any history?
No, sir, no history of any skin changes was present, sir. The swelling was asymptomatic. It was not associated with pain, and there was no skin changes.
So you said that gooseberry, size of a gooseberry. So what size and shape approximately?
Approximately 2 cross 2 centimeter and ovoid shape or hemispherical.
Okay. And which part of the thigh?
Sir, anterior aspect, upper 1/3 of left thigh, sir.
Upper 1/3 of the left thigh. So it was in the front or back? That was that you should have mentioned, and it is the same in size. It is, or it has increased.
It has progressed, sir. Progressed to in size gradually.
What is the current size
The current
that
size
you have not
it's
mentioned?
15 cross 10 centimeter.
So that is how many fold increase in the size. So why it is important to know? Do you get me or not?
Yes,
I am
sir.
audible?
Yes, sir. Yes, sir.
Kritika, sir is
Sir,
So why
asking
sir,
it is
how many
important
times
to,
it has become bigger. So, what is the relevance of the size progression? That is his question. Please
sir,
answer to that question.
yes, sir. When if the swelling is rapidly progressing, uh, we can know it as a malignant swelling. But swelling progressing over a long time may need not be malignant, sir. It might be a benign swelling,
so
slow progression.
you already you already said that it has increased in size significantly in last 2 years. So last
Yes,
six
sir.
months it has increased, or it is gradually progressing at a pace.
It is gradually.
Is there any history of sudden increase?
No, sir. No, by the history given by the patient, he has not noticed any rapid progression in the size of the swelling, sir.
Okay. Is it associated with pain?
No, sir. No, it is not associated with pain, sir.
And is it associated with any difficulty in walking
No, sir.
or any movements for that matter?
No, sir. No history of any restriction of movements. No history of any difficulty in walking, sir.
Okay. So the previous slide, please. So what are the causes except malignancy? Sudden increase in the size of the swelling.
Sudden hemorrhage into the swelling.
Sudden hemorrhage. Okay.
As maybe the patient might sustain some trauma of the swelling and might be hematoma formation.
So patient is not having any history of trauma.
Yes, sir. Malignant
Okay.
transformation in a previously benign swelling.
So what are the other histories that you should look for if at all there is any suspicious malignant transformation?
A sudden increase in size,
Yes.
appearance of pain,
Yes.
and appearance of any skin changes like ulceration, and presence of any compressive symptoms, sir, like paresthesia and restriction of movements. And if a previously mobile swelling has become fixed.
Yeah.
So that is your on an examination you will be able to make out whether the swelling has fixity has appeared. Hello, are you there?
Yes, sir, I am there, sir.
Okay, so before development of ulceration, are there any symptoms that you should look for? Skin changes, what skin changes you expect?
Sir, some discoloration due to increased vascularity might become bluish discoloration can be present, sir.
So it is the increased vascularity
Yes.
that is why we are more concerned. That can be there if a swelling goes a malignant transformation. So there can be visible dilated veins.
Yes.
Bro. So and how come you know that patient is having carcinoma head of pancreas diagnosed?
The patient was got admitted in his own place, native place in Thoothukudi, sir, for complaints of jaundice. Before 2 months, he has got admitted in Thoothukudi hospital, and patient was referred.
Those wordings are totally, it comes in the surgical terms. So why did the patient go to the hospital? And
The
there, how was
patient,
she diagnosed? You straight away put it as obstructive jaundice, carcinoma of the pancreas. Did the patient go with the diagnosis of obstructive jaundice and carcinoma of the pancreas? to the Thoothukudi Medical College Hospital. So when
No,
did
sir,
the
the
patient go
patient
to Thoothukudi Medical College Hospital? For what
before
complaints?
2 months
For what complaints? Which started first?
for complaints.
Which started first, and how it progressed, and how long did it progress? Then only you can say this, is it obstructive jaundice or hemolytic jaundice? You cannot say. So when did the jaundice start? What are the associated symptoms? And why did the patient go there? And how was she diagnosed? And why was stent? And how was she diagnosed? Without this, you straight away go to the carcinoma to the pancreas and obstructed, evaluated for obstructive jaundice. Did the patient go with the preformed idea that she is having obstructive jaundice and carcinoma to the pancreas?
No, sir.
The history of present illness should mention about the jaundice and other thing. Patient underwent some treatment.
Yes, sir.
Yes.
Now tell me how did she go? Give an elaborate history of jaundice.
The patient had complaints the patient had history of jaundice for the past 2 months, for which and also the patient had history of pruritus, passing high-colored urine and clay-colored stools, for which he sought treatment at Thoothukudi Medical College Hospital. There he was treated with treated conservatively, and with radiologic imaging investigations were taken, and it was suggested that he had to undergo ERCP stenting and was referred to Tirunelveli Medical College Hospital before 15 days, sir.
All at the same time. Jaundice, pruritus, high-colored urine. So, Professor Ajay, sir, good evening. Take over, sir, please.
Kritika, I just wanted to know that, has this patient come to you for the swelling of the thigh, or he has come for the jaundice to you?
Sir, before 15 days, the patient was admitted for obstructive jaundice and was discharged after stenting procedure, sir. Now he has come. He was admitted before 5 days for the swelling, sir. Complaints of swelling.
But this swelling is there for 2 years, isn't it?
Yes, sir. The swelling was there for 2 years.
So he has
The
never come for
patient-
that swelling yet.
Yeah, yes, sir. The swelling had no complaints till now. While evaluating for jaundice, they noticed the swelling, and they took imaging also in Thoothukudi College, sir.
So what do you think, your case is primarily of a obstructive jaundice or the swelling of the left thigh?
Swelling of left thigh. Now, swelling of left thigh, sir.
No, but I think that is the main complaint. The patient is having the jaundice, the patient is having the itching, all those problems which are there. This swelling is there lying for a long time, for 2 years now.
Yes, sir.
Okay. So probably you have to reverse your case from the swelling of the left thigh to the jaundice patient presenting one of the symptoms is that the swelling is there. So the presenting chief complaint in this patient will be probably a jaundice here. Okay, anyway, because you have taken this case like a swelling of the left thigh. Okay. So what did you ask? This is a confirmed case of carcinoma head of pancreas?
Yes, sir.
Biopsy proved?
Yes, sir. Biopsy proved, sir.
Okay, and only stenting has been done.
Yes, sir.
It is not for any curative operation, is it?
No, sir.
Or there is a plan for that
It's
after the stenting?
advanced. Yes, sir. Yes.
Is there a plan for that?
You are not sure. You are not sure.
Yes, sir. That's planned.
Whether it's hit of the pancreas or not, you are not sure. You're just saying biopsy proved. Was a biopsy taken? What are the
Yes, sir.
investigation
Biopsy
done?
has been taken.
What was the investigation done? Where was the
Sir,
growth?
Yes, sir.
Where was growth? What was the size of the growth? What is the reason for stenting? Why not a definite procedure? So you don't mistake me. I'm just pointing you the fault. You have to ask in history, as Professor Ajay Khanna said, this is going to be main of a obstructive jaundice case. So you have to ask in detail about the history.
Yes, sir.
Okay. Do they do a biopsy in a pancreatic malignancy? Do they put in a needle and do a biopsy? I won't do. So you're not sure about it, okay?
Again, please, Kritika, please tell whether the patient has came for the treatment of the thigh swelling or jaundice.
Sir, now for the thigh swelling is admitted, sir.
So, what about the disease patient is explained? Whether the patient is going to go for surgery, whether the patient is going to go for chemotherapy, what is the further plan of action? Patient knows, number one, and patient has themselves planned.
Sir, for the swelling, the
If the
patient
patient had come for a swelling, he could have undergone the surgery for the swelling rather than going in for a bypass procedure for jaundice. Do you understand me?
no, sir.
The patient has come for a swelling, could have easily undergone some
Yes, sir.
surgery for the swelling or some investigation. So they thought this is more important.
Because that is more life threatening for the patient.
Yeah.
And when patient has came to us, we have to explain that part, that jaundice has to be treated. This swelling, we can go for any investigation, we can confirm that this is malignant or not. But at the same time, bigger concern has to be obstructive jaundice with a malignancy, as you are saying.
Yes, sir.
Rita, can you go to the next slide?
Yeah.
Sir.
Go to the next slide.
She got confused. She was very particular about swelling only. No, the previous one.
Previous slide, yeah. Okay, tell about all those no histories which are there. Ulceration of swelling of the left thigh, isn't it?
Yes, sir. First, I have asked for loco-regional effects of the swelling. That is, if there is any ulceration of the swelling, and if the swelling has caused any compressive symptoms like restriction of limb movements, paresthesia of the lower limb, or edema of the lower limb.
Which
This
swelling in
is-
that area can cause the paresthesia? Which swelling in that area can cause the paresthesia?
Sir, any lymph node swelling compressing the neurovascular structures.
Which lymph node swelling can do that?
The inguinal.
Tell the swellings where there is paresthesia. जो है.
Paresthesia is over which part? All thigh?
Over anterior aspect of the anterior cutaneous nerve of the.
Paresthesia can be because of either there is a nerve involvement itself or there is some compression from surrounding areas in that area. So what tumors can arise from the nerve which can cause the paresthesia?
Neurofibroma, sir. Malignant
One is
peripheral
neuro.
nerve tumor.
Yes. Yes. Tell some other nerve tumors.
The schwannomas.
Adenoma, yes.
Yeah.
Okay. Why there should be edema?
Lymphatic drainage obstruction, sir, or by venous
What?
congestion.
It can be lymphatic as well as it may be venous also. So which swelling in that area can
Yes.
cause this edema?
Sir, lymph nodes, inguinal group of lymph nodes enlargement can cause edema, sir.
And venous? Why say it is a DVT?
Yes,
Okay, why say it is a DVT? Deep vein
yes, sir.
thrombosis is there. Will there be edema or not?
Yes, sir. There will be edema, sir.
What is post-phlebitic syndrome?
superficial thrombophlebitis occurring post DVT, sir.
Superficial.
Post thrombotic leg.
Post-phlebitic,
Sure.
post-thrombotic. It is
Sir.
following the DVT, you know? Following the DVT, there is a edema, persistent edema, which is there. And that is the post-phlebitic syndrome. And ultimately, it will lead to secondary varicose veins, the venous ulcerations, all those things will be there.
Yes.
Okay. No history of fever. Now tell, is a swelling for 2 years. What is the significance of fever here?
Sir,
Swelling of 2 years is there. What is the significance of fever? Okay.
sir,
In your
sir,
patient, if there is a fever is
I'm
there,
just
what you will think in your patient?
might be due to tuberculosis history where there is healing rise of temperature. Maybe the swelling might be due to matted lymph nodes of the inguinal region.
I will think more of the
Or
cholangitis in your patient. In your
Wait,
patient, I am asking.
yes, sir.
The patient is having the obstructive
Jaundice.
jaundice.
Yes, sir.
Yeah, so you will think more of the cholangitis rather than a,
Cholangitis.
because of that particular swelling which is there. You know?
Yes,
you already said that stenting has been done. So post procedure, patient can have.
yes, sir. Cholangitis.
Which trauma can lead to the swelling like that? You said no trauma to the left thigh.
Yes, sir. Yes, sir.
So,
Some organized hematoma or in some cases myositis ossificans can
yes.
mimic the swelling.
Now, sometimes it is said that there is a sarcomatous swelling is there that is precipitated by the trauma. Okay, though it is not very true, but the patient always associate with that.
Yes, sir. That trauma brings the notice of
Yeah,
the
notice of
patient
the
to the
man. Yeah,
swelling.
that's right. Yeah, right. No radiation or no history of radiation exposure or chemical exposure.
Yes, sir.
How it is related to that swelling?
Sir, in cases of sarcoma, chemical exposure like thorotrust and polyvinyl chloride exposure can be predisposing factors, and radiation exposure is also significant in cases of soft tissue swellings, sarcomas.
If the history of radiation exposure is there, what are the cancers which can be predisposed?
Sir, in undifferentiated pleomorphic sarcoma, angiosarcoma, leiomyosarcoma, fibrosarcoma, sir, and in post uh,
Why did you ask about swelling elsewhere in the body?
sir,
Why did you ask about that?
the patient in my patient as he's having he's a patient of with obstructive jaundice, might be carcinoma of head of pancreas, and he might have lymph node swellings elsewhere.
No, let us forget at this point for the swelling elsewhere about the
Yes, sir.
carcinoma head of pancreas. Let us just restrict to this swelling only.
Okay,
So
sir.
why you are interested to know swelling elsewhere in the body? You know, any tumors which are multiple?
Yes, sir. Um, neurofibromatosis.
Yes. Yeah, neurofibromatosis may be there, lipomatosis may be there,
Yes, sir.
hmm, and lymph node involvement may be there.
Yes, sir.
Okay, that can cause the swelling in the other parts of the
Yes.
body.
Yes, sir.
Okay. Why history of cough and hemoptysis?
Most common site of metastasis in soft tissue sarcoma is to the lungs. So I asked for lung metastasis. To rule out lung metastasis, I have asked for cough with hemoptysis, sir.
And history of jaundice is present. It is because of carcinoma of pancreas, is it?
Yes, sir. Yes, sir.
Did you know that what type of the jaundice it is? How would you differentiate between a hemolytic jaundice and the obstructive jaundice?
The indirect bilirubin is more than
No,
the direct.
clinically. No, we are asking clinically. What is acholoric jaundice? What is acholoric jaundice? Now, can you tell any jaundice where the sclera is yellow, but the urine is white?
And
You know what is
I don't
hemolytic
know.
jaundice?
Yes, sir.
So what happens in the hemolytic jaundice? Achha, what is the reason of yellow color in jaundice patient in the urine? Why it is yellow? Because of which substance it is yellow?
Urobilin, sir.
Urobilin is absent. है ना? In case of obstructive jaundice, urobilin is usually absent. Once it starts coming, it means the patient is improving. So it is not because urobilin is there.
Fine.
It is because of bilirubin. Okay, this yellow coloration is because of bilirubin. And which bilirubin it will be?
In obstructive direct, sir.
So in a case of acholoric jaundice or hemolytic jaundice, because urine, the bilirubin is unconjugated. Okay.
Yes, sir.
So that is why the urine may be white in color, but the sclera will be yellow. So that is the acholoric jaundice.
Yes, sir.
Yeah, Dr. Abhay, you wanted to ask something?
Yeah, thank you.
Yeah.
Kritika, just tell me whether these two, obstructive jaundice because of pancreatic adenocarcinoma and soft tissue swelling, are related to each other. Did you hear me?
Yes, sir. I heard, sir.
Do you think they are related to each other?
No, sir.
Why? What is the embryology of soft tissue tumors and what is the embryology of pancreatic tumors?
Sir, soft tissue tumors arise from the mesenchymal stem cell rest, sir.
See, there is ectoderm,
Undifferentiated
mesoderm,
mesenchymal.
endoderm.
Yes, sir.
So you give me answers in this. Soft tissue tumor arises from what? And pancreatic tumors arise from what?
Soft tissue tumors arise from the mesoderm, sir.
Correct?
Pancreatic tumors arise from endoderm, sir.
Correct. Absolutely. So these are two different tumors in a same patient you are treating.
Yes, sir.
The question arises here is this is a obstetric jaundice, proved pancreatic cancer as I take it, scheduled for maybe whatever intervention, and you have got a soft tissue tumor which is turning into malignancy. This is what you are trying to tell us, correct?
Yes, sir.
So I request the examiners to stick to one and go ahead with discussion disregarding other cases. This is for you, Kritika, because it's a difficult case to answer. Thank you.
Thank you. Thank you.
Okay, Kritika, can you
Khanna
go
Sahib,
to...
Parmar Sahib, please take over.
Yeah.
Yes,
Let
sir.
us stick only to now the swelling of the thigh only, okay? Because you are not prepared for the jaundice. So let us stick only to the thigh swelling, na?
Yes, sir.
Because you
only thing,
thought probably, yeah, we'll be discussing only the thigh swelling. We'll not discussing about the jaundice. But anyway, now let us go ahead with the thigh swelling only. Go to the next
sir,
slide now. Yeah, please,
only thing
Dr.
that,
Parmaria. Yeah.
yes, sir. So only thing that I want to say that this is not quite uncommon. When you go to an exam, you have a patient of inguinal hernia, but patient is having a nevus or pigmented nevus or any swelling in the scalp. Examiners start asking that. So concomitant to pathology is not uncommon. So you should be mentally prepared that you are prepared, you are hernia, and then examiner starts speaking about the melanoma and whatnot, pigmented nevus and whatever the discussion can go to the swelling. So please be prepared. Okay, now you can
Yes, sir.
proceed.
Okay, go to your examination now. Yeah.
On
Okay.
examination, the patient is conscious, oriented, afebrile, ECOG status 1. If patient is icteric, the patient has pallor. The vitiligo patches were present over left veto, medial aspect of right leg above medial malleolus and lower lip. No clubbing, no fetal edema, no generalized lymphadenopathy. Local examination. After consent and adequate exposure, patient was examined in standing and supine position. On inspection, a swelling of size about 15 cross 10 centimeter was present over anteromedial aspect of upper one-third of left thigh. The swelling is ovoid in shape, extending up to groin tibia superiorly, inferiorly up to about 25 centimeter above the knee joint, medially up to the midline, and laterally extending up to the line from the mid-inguinal point. Edges are ill-defined, surface appears bosulated, skin over the swelling has prominent veins, crooked scar is present, varicose veins were present over both lower limbs, and surrounding skin appears normal. On palpation, a warmth is present over the swelling. The swelling is not tender. A single swelling of size of 15 cross 17 centimeter was present over the anteromedial aspect of upper one-third of thigh. Extent was confirmed. Surface irregular. Margins are ill-defined. The consistency was variable. Skin over the swelling is pinchable, and the swelling is mobile in horizontal and vertical directions. Plane of the swelling probably above the muscle. No muscle wasting noted. Sensation around the surrounding area is normal. Movement of nearby joints not restricted, and all peripheral pulses were felt. No palpable inguinal lymph nodes. Left supraclavicular node was enlarged. A single node of size about 3 cross 2 centimeter, and swelling was firm in consistency. A systemic examination for abdomen, no palpable mass or organomegaly felt. Cardiovascular system S1 and S2 heard, no murmurs heard. Respiratory system bilateral air entry was present and no added sounds. To summarize my findings, a 45-year-old male who is a known case of carcinoma head of pancreas with obstructive jaundice, now presenting with complaints of swelling over left thigh. On examination was icteric, anemic, has vitiligo, has left supraclavicular lymphadenopathy, with a 15 cross 17 centimeter swelling over the anteromedial aspect of upper one-third of thigh. It is ovoid in shape, irregular surface, ill-defined margins, variable consistency, above the muscle plane with no compressive features.
Diagnosis?
Diagnosis: a case of soft tissue swelling of anteromedial aspect of upper one-third of left thigh, probably sarcoma.
Go to your inspection site.
Is it a compressible swelling?
No, sir.
Kritika,
It
is it a
was not
compressible
compressible.
swelling?
No, sir.
It's
No,
not.
sir. It's not compressible.
See, please go to your general examination slide, please.
Yes, sir.
See, you have written that patient is icteric as well as paler. Can you make out both? When patient is already having a jaundice, can you make out the patient is anemic too?
We can take a look at by in the tongue that we can see the pale tongue.
So where you look for the jaundice and where you look for the anemia?
For jaundice, I looked in the upper sclera in the nail bed. Sir, for pallor, I looked at the tongue.
Usually it is difficult to differentiate whenever the patient is icteric, you cannot make out the paler part.
Yes, sir.
Okay, you can please go to the next slide. So on inspection, can you make out that mid-inguinal point?
No, sir.
Okay, can you describe the true cut biopsy scar, where it is and what it looks?
Sir, it was present in the.
So when true cut biopsy was taken?
Sir, in the prominent part of the swelling, sir, over the
When,
anterior
how
aspect.
many days back? Because that you have to mention in your history that some kind of biopsy or the patient might tell you that some with the needle they have taken the try to take the biopsy or FNAC. So any procedure has been done that you have to mention in your history.
Yes, sir.
So before how many days?
Sir, before 4 days, sir.
Before 4 days.
Yes, sir.
Okay. So after biopsy, whether patient had bleeding over there or not?
Sir, my mild bleeding was present.
You said that varicose veins present. Can you
Yes,
describe
sir.
which on inspection of, see again, once you say that there is a varicose vein, then you have to describe it.
Sir,
Again,
elongated.
we want to stick to the swelling only, but in
Yes, sir.
examination, examiner might like that you have to speak, might want that you have to speak.
Yes, sir. Sir, elongated tortuous vein was present along the course of great saphenous vein, extending from the left leg from the ankle joint.
Why it is important to tell is because you have put your diagnosis as sarcoma, and
Yes, sir.
sarcoma there can be dilated veins. So on inspection, if you say varicose vein, rather you have to say that which area of the veins are dilated, the pattern of the dilated veins, so that at the end of your inspection or in palpation, you can say that the dilated veins are because of the sarcoma or dilated veins are or the third pathology that patient is having.
Yes, sir.
Khanna sir.
Okay, so your patient, have you told about the abdominal findings?
Yes, sir. The abdominal findings, I could not palpate any mass or there was no organomegaly, sir.
Now, in a patient where you are suspecting a carcinoma head of the pancreas, so you will
Yes, sir.
just finish your abdominal examination by saying no palpable mass and no, again, you are only because going only to the thigh swelling. So that is why you're not done all, because otherwise so many things you have to tell in the abdominal examination, this patient at least. Now, your patient has got a carcinoma head of the pancreas. Your patient has got big lymph nodes which are there in the neck. There is a swelling which is there in the inguinal region, in the inguinofemoral region.
Yes, sir.
So can you correlate all these things in one diagnosis? That there is a tumor from the pancreatic area, or
Yes,
it
sir.
is there or not, we are not still sure about that because your abdominal findings are absolutely normal.
Yes, sir.
So there are big lymph node mass which is there in the neck,
Yes, sir.
mass there in the inguinofemoral area, and the patient is having jaundice. Can it be all because of lymph node mass there? Only because of the lymph nodes? Some pathology from the lymph node causing all these things.
Sir, lymphomas.
Can it be lymphoma? Did you think about the lymphoma in this patient? Did you check about other lymph nodes, axillary nodes, other
Yes,
inguinal
sir.
area?
Other nodes were not palpable, sir. Only left supraclavicular node was palpable.
And the patient has got varicose vein on both sides?
Yes, sir. Both say both legs, sir.
Okay. So tell what is your diagnosis? Let us, because there are so many things involved in this patient, Joanna. It's a definitely difficult case for
Yes.
diagnosis. Yeah.
Even
So
we
what
can
is
see.
what? Yeah.
Sir.
So what diagnosis you have made? Go to your diagnosis one. Yeah.
Sir, a case of soft tissue swelling of andrometrial aspect of upper one third of left thigh, probably sarcoma, sir.
No other differential diagnosis you want to keep here except the sarcoma. Sarcoma there for 2 years.
Can it be liposarcoma?
Yes, sir. It can be liposarcoma also.
But I think you have to put a list of differential diagnosis in your patient. And definitely it is required.
Yeah.
And you cannot forget in this patient that the patient is having the jaundice. And you cannot forget about those big lymph nodes which are there in the neck.
Yes, sir.
So either those because of the carcinoma head of the pancreas, or it may be these lymph nodes may be because of the carcinoma head of the pancreas itself.
Yes, sir.
You know the carcinoma of the stomach can metastasize to the left axillary nodes.
Yes, sir.
What is that called as?
Irish.
Irish nodes, yeah.
Yes,
So any abdominal malignancy can go to the neck and also to the axilla and the inguinal region.
yes, sir.
So if you have to explain everything by one diagnosis here, so I will think either you are dealing with a case of lymphoma or it is a carcinoma head of the pancreas with metastasis to the neck as well as to the inguinal region. Yeah,
Abhay sir wanted something. Abhay sir
yeah,
raised it.
Dr. Abhay. Yeah. Dr.
Abhay
Abhay?
sir,
Just to interrupt here. Now, I think she is confused as much as I am. What I should be treating? Carcinoma have the pancreas or the soft tissue tumor? So, Kshitija, I just want to know what will be your priority in treatment?
The treatment of the
How will you
jaundice
investigate this patient that may lead you to priority in treatment?
mm,
What will you investigate with biopsy to know what would you like to treat first?
um, I would investigate by taking MRI of the local part, sir.
No,
And
you
then
investigate this
before,
patient. There are big nodes in the supraclavicular region.
yes, sir. Sir, PET-CT can be done.
You do whatever you want. How will you align your treatment as to treating soft tissue tumors against the pancreatic carcinoma? Which will you give preference and when? It's a difficult case. For me, you have already passed the exam, but still,
Sir, first we'll treat for symptoms of obstructive jaundice. For if there's cholangitis, we'll first take care of that, sir. Then
no, forget
we
the ancillary treatment. I want to know
yes, sir.
focused treatment. How will you go about it? There is a soft tissue tumor on the medial aspect of
Yes, sir.
the thigh,
Sir,
which is a sarcoma,
yes,
and
sir.
there is a pancreatic tumor, which is adenocarcinoma. That you have proved
Yes, sir.
already.
Yes, sir.
Now, the question comes is, how will you treat the nodes?
Sir, a node, we have to confirm whether the metastasis is from the pancreatic tumor or the soft tissue swelling, sir. Because
Absolutely correct.
yes, sir. Soft tissue sarcomas are rare to metastasize to lymph nodes. Yes, sir.
Correct.
Yes, sir.
So let us assume that the metastasis to supraclavicular region is pancreatic carcinoma.
Yes, sir.
Under the treatment protocol, do they become operable or no?
No, sir, it becomes inoperable.
Absolutely. So the patient is already stented,
Yes, sir.
still jaundiced.
Yes, sir.
In your investigations, are the bilirubin coming down or no?
It is coming down, sir.
It is coming down. So
Yes, sir.
stenting is possibly working.
Yes, sir.
So now is your focus on the soft tissue sarcoma? Since your topic is soft tissue sarcoma, I am asking you these questions.
Yes, sir.
What are the complications which are being done or created by this soft tissue sarcoma of the medial aspect of the thigh?
Sir, it is locally invasive and might invade into the neurovascular structures. Thereby,
Why do
we
you think
cannot,
so? Why do you think so?
sir, due to its location, sir, it is almost near the femoral vessels, sir. So, if we
Correct.
allow it to progress, we will not be able to resect the tumor, sir. If we intervene earlier, we can resect the tumor and we can give the adequate clearance.
Correct.
We can
So
do
now,
curative resection, sir. And we can also
see,
spare the limb.
Kshitija, never, Kritika, never open your mouth more than what is asked in examination.
Yes, sir.
Okay. So
Yes, sir.
what I'm trying to tell you is the focus is shifting because you know that pancreatic cancer has already spread to the supraclavicular nodes. It's unlikely, but you have to investigate this patient to prove that supraclavicular is because of pancreatic malignancy. And as I said earlier, pancreatic malignancy, let us keep aside. Soft tissue sarcoma is the one which you are trying to treat. Now, let
Yes,
us come to investigations. I am not a connoisseur on soft tissue sarcomas. I leave it to Dr. Khanna and Dr. Parmar. But what are the investigations that you will do to know whether it is resectable and curable? That is my question.
yes, sir. Sir, MRA local part, sir.
What are you looking at when you do MRI in the local part?
Sir, the plane of the swelling, sir, and whether it is restricted to one compartment or crossing the facial planes. We
My,
can
my
look
question is
for
very
the
simple.
yes, sir, vessel
I have been
encasement.
observing that when resident sends a patient for MRI, CT scan, ultrasound, they never communicate with the radiologist as to what they want when they are contemplating surgical resection. So, what are the things you will ask the MRI, CT, or USG person with respect to this soft tissue swelling, which was soft and now become hard, which was mobile, which has become fixed? What are the things that you want to gather information whether this thing can be surgically resectable? What information do you want?
Sir, vessel encasement, neurovascular invasion, and
How does
about the plane of the
ultrasound,
tumor.
CT, or MRI tell you neurovascular invasion? What are the findings that give you that information?
Sir, in MRI T2 weighted image, we can look for neurovascular invasion. Sir. Nerve encasement and vessel encasement can be seen, sir, in MRI.
What report do you expect from a MRI radiologist or a CT radiologist or a sonologist with which will correlate with the clinical findings?
Sir, the enhancement of the soft tissue, sir, the components,
The
whether it
clinical
is
examination of yours tells me very clearly that XYZ is likely to be involved. What is that structure?
sir, femoral vessels, sir.
Femoral vessels. What
Yes, sir.
tells you that femoral vessels are involved?
As I mentioned that the extent of the swelling is up to the midinguinal point, sir.
That's fine. There is no DVT. Now what? Is varicose veins because of the soft tissue tumor important marker that there is compression of the greater saphenous vein?
Uh, yes, sir. Um,
So you have
but
to correlate your compression symptoms with the clinical examination. That is all that I want to tell you.
okay,
Correlation of clinical findings with investigations should give you a fair assessment of what is getting compressed or blocked. Compression and blocking is two different things that we can discuss later. But I think you're doing a good job in this case presentation, because it's a difficult case to actually present, and at MS level, we have to be, the examiners have to be careful. Thank you so much. Khanna Saab, le lo.
Ritika, what is the biopsy report here?
sir. Uh,
It has been done, no?
Perhaps, yes,
Yeah,
sir, it
yeah.
has been done.
Mhm.
It was the fragments of strated squamous epithelium, malignant neoplasm, which was composed of cell. Impression was malignant melanoma, sir.
So when you got this biopsy report, did you went again to the patient to examine?
Yes, sir.
What thing did you examine in this patient again? Clinical examination. And we were thinking about the lymph node mass here. We were thinking about lymphomas. We were thinking about sarcomas. But once a biopsy report has come as a malignant melanoma,
Yes,
then
sir.
what other things you are going to see in the limb?
Um, Sir, whether there is any patch, melanotic
Yeah.
patch
Did
or
you? So
nodules around the swelling.
okay? Did you look for that?
Yes, sir.
You did not find any blackish patch, or you did look at the toes also, at the nails. There was no growth was there. Did you see
No,
for all
sir,
those things?
no, I could only make out this vitiligo patches, the three patches, sir, as I have shown in this clinical photos. There was no patches around the swelling in the
What
thighs,
are
sir.
the various types of melanomas?
Uh,
what are the various types of melanoma? You know, once the biopsy report is melanoma, then you have to be thorough with melanoma, jo hai na? Everything
Yes,
you have to
sir.
read
We
about
have,
melanoma.
yes, sir. Amelanotic is a type, sir. Nodular.
That is the rarest one, amelanotic one.
Yes, sir.
Have you read melanoma?
No, sir.
See, once the biopsy report is melanoma, then you should read it.
Yeah.
You should have rather.
Okay. Tell about the other reports.
Sir, initially, ultrasound the local part showed heterogeneous mass in left upper thigh arising from subcutaneous and intramuscular vein, superficial to the femoral vessels with minimal peripheral and central vascularity. Had possibility of soft tissue sarcoma, sir. MRI on taking MRI groin, the impression was that of subcutaneous cavernous hemangioma.
Did you have the ultrasound of the abdomen here?
Sir, we have done, sir, but I have not added those in the slides, sir.
There were no secondaries in the liver.
No, sir.
What about that cervical lymph node? Have you done any investigation for that?
No, sir, it has not been done.
PET CT has been done? PET scan?
No, sir.
Okay.
No, sir. The wide local excision was done and the cut section was like shown this. Okay.
The biopsy report has come out melanoma here of
Yes,
this
sir.
specimen. So do you think this is a primary melanoma or this is the lymph nodes there in that area?
I'm not sure,
Because
sir.
the skin doesn't look to be involved here, you know. Skin looks
Yes, sir.
spared.
Yes, sir.
So it has to be the secondaries in that, in the nodes there.
Oh, yes, sir.
Okay, the primary has to be there in the limb somewhere. Or
Yes, sir.
it's a male patient, na?
Yes, sir. He's a male.
Yeah. So you have to see for his penis. Did you check for the anal region here?
Yes, sir.
Because the secondary and the inguinal nodes from melanoma can come from the penis. It can come from the anal region. It can come from the limb. So all these things you have to examine once you get a patient with a melanoma.
Okay.
And in the case of if it is a lymph nodes are there, then only wide excision is not the treatment for that. You know? You have to go for at least ilioinguinal dissection, at least. But probably in this patient, already the lymph nodes are there in the neck also. And I am
Yes,
not
sir.
sure still that this patient is having the jaundice because of the carcinoma hydropancreas. Are you sure about that? It's a proved adenocarcinoma of the carcinoma hydropancreas?
Yes, sir. It's a proven carcinoma,
How it
sir.
was proved? It is not
Sir,
because of the extraductal compression of the lymph nodes there. That's what I'm asking about the abdominal findings here. That what is the report of the ultrasound of the abdomen? Because if you have to fit this patient in one diagnosis now, so this is a patient with a melanoma causing the obstructive jaundice because of the ductal obstruction at the peridocal area and with the lymph nodes in the neck also. So this is already a incurable condition here. Right? Probably only the palliation has to be done for whatever the reason. The patient having jaundice, you have palliated already that, and probably nothing much can be done for this patient. That is my proposal. I think Dr. Parmar and Dr. Abhay can tell about that. Yeah, Dr. Abhay, please.
Hello.
Yeah.
Have you read Bailey Love textbook of surgery?
Yes, sir.
What is the famous sentence when you suspect a melanoma? This is a question which is usually asked when a candidate does well. Beware of glass eye and a large liver. The diagnosis is melanoma. That's written in age-old Bailey Love when I studied it. Remember that. So when you want to
Sir.
combine this diagnosis of obstructive jaundice and a melanoma with supraclavicular nodes, please remember that it is melanoma that causes all these symptoms and not this. Now, you've got a biopsy diagnosis, I believe, of pancreatic adenocarcinoma. Now it becomes complicated as to supraclavicular.
I think she's not sure about that, Dr. Abhay.
Yeah,
She's probably not sure about that, that it's a
correct.
adenocarcinoma of the pancreas. She's not sure about that, yeah.
If she's not sure about it, then we
Yeah.
should focus on malignant melanoma, can
Yeah.
give rise to all these sort of symptoms and will be treated. Of course, there is no treatment now that it has reached supraclavicular nodes. So this patient requires village therapy, according to me. Thank you.
Dr. Parmar, you want to ask anything? Otherwise, we close the case here.
No, no, sir, we can close this case. Actually, it's a very complicated and she has done very well.
Yeah.
But the
Yeah,
only
it's a
thing
very
that
complicated. Yes.
very complicated, sir. So I just want to say that every PG, actually those who are PGOs who have joined, they should be mentally prepared if there is another pathology also, and it might come from out of blue moon that examiner started asking all these things. In this patient, yeah, it was a very complicated case, but she did well.
Yeah, Kritika, it was a very difficult case. Now, the lesson from this case is that if there are multiple pathologies which are there, for the examination purpose, you have to read all those pathologies. So you should have
Yes,
prepared
sir.
with the carcinoma head of pancreas here. You should have prepared with the sarcoma here. You should have prepared with the melanoma here. So all those things has to be studied, na? Because the
Very good.
examiners will go in which way, you never know about that. Na?
Yes,
Okay, thank you, Kritika.
Thank you,
Dr.
sir.
Kanegal, can we close this case?
yes, sir. Please, we can close.
Yeah. So who is the second one? Dr. Kanegal? Is it there?
Yeah, Dr. Meet,
Yes, sir.
you can start presenting.
Yeah.
Kanagwel, sir.
Dr. Meet, you can share, yeah. Make it full screen.
Yes, sir.
Okay. Make it full screen.
In the bottom right corner, there is
Yes.
a presentation.
Yeah,
Ah.
yeah. Okay.
Yeah, yeah, yeah.
Okay.
Yeah.
So can I start now?
Yeah, you can start here. Yeah.
Yes, sir. Good evening, everyone. I am presenting a case of peripheral vascular disease. The history goes is a
Go
56
to
year
your, go to your first slide
old
first.
male.
Who is your, yeah, go to your first slide.
Yes, sir.
Tell from which place you are. Who is your mentor?
Yes, sir. My mentor is Dr. Kirit Parmar, sir. And sir, I am a resident, third year resident in NHL IMC Ahmedabad.
Yeah,
Sir,
go ahead.
he's my student, so better you
Okay.
ask more. It will be
Right.
more helpful
Right.
for him, sir.
Okay.
I'll be
Okay.
there, but it's my request.
Sure, sure, sure. Yeah, go ahead. Meet.
Yes, sir.
Yeah.
A 56 years old patient named Premji Upadhyay residing in Ahmedabad working as a laborer belonging to lower socioeconomic class presented to the surgery department of our hospital with following chief complaints of blackening of foot toe of left foot since 5 days, associated with blackening of third toe of right foot since 1 month, associated with pain on and off in both legs since 3 months. Patient was relatively asymptomatic before 3 months. Then he experienced pain in both legs below knee, in calf region. Insidious in onset, cramp-like in nature, gradually increased in severity from mild to moderate. The distance of walking became progressively short as he was compelled to take rest for relief from pain. Associated with blackening of foot toe of left foot since 5 days, and blackening of third toe of right foot since 1 month, which was insidious in onset and progressed gradually from tip of the toe to the base of the toe, initially bluish purple, then progressing to black in color, and there is no discharge or bleeding, and there is no foul smell. Similar complaints 1 year ago with bilateral lower limb pain, and for which bilateral common iliac artery PTCA stenting was done. Known case of diabetes since 10 years on treatment, known case of ischemic heart disease since 10 years on treatment, operated case of coronary angiography 10 years ago. Not associated with trauma, fever, discharge of bleeding, blurred vision, impotence, abdominal pain, chest pain, vertigo, blackout. In past history, no past history of tuberculosis, hypertension, thyroid disorder. Family history is not significant. In personal history, mixed diet has adequate 1 to 2 packs per day since 25 years. Has no history of any allergy. So can I continue with examination?
No, no. Go to your first slide. Go
Yes.
to your first slide here. Okay. Now this patient, now first thing is that for making the PPT, it is always advisable that you write in running language, not all in the capital one. Here you are writing all in capital, and it was so difficult to read that. You understand
Yes.
that?
Yes, sir.
Okay. So it has to be not in the running type of the fonts has to be there.
Okay, sir.
And do you know the difference between since and for? What is the difference between since and for?
Yes, sir. Since
What
means
is the difference?
if it is since 5 days, then the complaint or anything is started from that day and it is present till this day.
Since is exact. Okay, since is exact.
Yes.
So from which particular day it has started. And for is approximate. So at many
Yes.
places you have written since, that is not correct.
Okay, sir.
Okay. Now
Yes.
his chief complaint is mainly the pain or it is the blackening.
So the patient had complaint of first blackening.
Okay, that is his chief complaint, Jay.
Yes, a
He has
patient
come to the
presented and
hospital
had of
for the
complaint of
blackening.
blackening
Okay.
of the toe. And then
Okay. So left foot first and right foot. Now it has to be in order, Jay, no?
yes, sir.
Okay. So what will be the
Yes.
order here?
So chronology according to
Yes.
patient's history, the order should
Yeah.
be the right because it is since 1 month, which was earlier. But the patient was compelled to come to hospital because of blackening of foot, left foot. So that's why I was.
So what do you think? The pain should be the first complaint here or the blackening should be the first complaint here? According to chronology.
According to chronology, pain should be the first complaint.
So that is the chief complaint, na? So here you have
Yes.
what? Okay, so the chief complaint will be pain in both the legs for 3 months, not since 3 months, for 3 months, blackening of the right left foot for 5 days, no, blackening of the right foot for 1 month and blackening of the left foot for 5 days. Na? So that should be the order in telling about the chief complaints. Okay, go to the next slide.
Yes.
Yeah. Go to the next slide. Okay. Patient was relatively asymptomatic before 3 months, then he experienced pain in both legs, in calf region, insidious in the onset, cramp-like in nature. What is claudication? Is it claudication or not?
Yes, sir. It is claudication, sir.
What do you understand by claudication?
Claudication refers to the pain when the patient walks. Pain during walking is considered claudication. Pain while the patient exercises, walks is known as claudication.
Yeah, Dr. Abhay, please. Dr. Abhay?
Can you have a clear definition of what is claudication?
Yes, a claudication is defined as the cramp-like pain when the patient is walks for a certain amount of distance.
what is the history of the term claudication as to relation to Emperor Claudius?
So claudication is the name comes from the Roman Emperor Claudius, which where the Emperor Claudius noticed limping while walking.
So, what is the important word what you are trying to tell me?
Uh, Limping due to
Limping.
cramp-like
So,
pain. Yes.
claudication is defined as pain leading to limping. That is the
Yes.
complete definition of claudication. Very good. Go ahead. Khanna Saab, le lo.
What are the various types of claudication, you know?
Yes, sir. Vascular claudication, neurogenic claudication, venous claudication,
What is the difference between
physiological
arterial
claudication.
claudication and venous claudication?
So in vascular claudication, it is mainly due
No,
to the
arterial and
arterial
venous.
claudication. Yes. In arterial claudication, it is mainly due to the lack of blood supply due to stenosis or thrombosis of the artery, which leads to the uh, decreased blood supply in the tissues in the muscles, consequently leading
How
to
do
the
you
pain.
differentiate clinically whether it is the arterial claudication or venous claudication or neuroclaudication?
Yes. In arterial claudication, intermittent claudication is seen by the patient when the patient walks. Initially, there is no pain, but then the gradual pain is presented. In neurogenic claudication, the pain is presented on the first step itself, whereas in venous claudication, it is in a consideration of the position of the limb of the patient. Like if it is in dependent position, the pain is more, while the pain is relieved when the leg is elevated.
What are the various grades of the intermittent claudication?
Uh, so grade one is when the patient walks for a certain amount of distance, the pain develops cramp-like pain, which then disappears when the patient continues to walk. The second grade is when the patient walks for a distance, pain develops, but the patient continues, but the pain is still present, continues to walk when the pain is still present. And third grade is the patient is compelled to take rest because of the pain. And the fourth one is rest periods when the pain is at rest.
So black neodar. So he has started with the black neodar. You know, it is so difficult to read because it's all in capital letters here. From tip to toe to the base of the tongue. Actually bluish purple. The patient had a similar complaint 1 year back
Yes, sir.
of the pain or the gangrene.
So the patient is bilateral rolling pain, sir.
He did not have any black patches at that time.
No, sir. No patches at it.
Okay. Okay. He's known diabetic. He's known ischemic heart disease. Had coronary angiography 10 years back. So only coronary angiography was done or angioplasty was done?
Sir, angioplasty was done and stenting was done, sir.
Because you have written only angiography here, right?
So common endocarditis PT says stent was specifically the stenting was done, sir. And stenting was done in common iliac artery, sir.
The coronary is different.
Coronary angiography was done, sir.
But not the angioplasty.
Yes, sir.
Okay. Okay, next slide. Fever, discharge, blurred vision. Why the blurred vision? You ask about that? Why did you ask about the blurred vision?
To look if any trauma is there or not. The patient is having any trauma or not.
So in a patient of the arterial disease which is there, you are thinking in terms of trauma there in the
maybe recent
blurred
trauma.
vision?
Yes, sir. Or maybe some discharge may be present or other reasons of gangrene rather other than vascular disease where bleeding can be present.
The patient is having the arterial disease, no? So
Yes,
there
sir.
can be the arterial eye also may be involved. The retinal arteries may be getting involved in that. No? That is why there may be blurred vision.
Yes,
Okay,
sir.
patient is diabetic, so the patient might be having diabetic retinopathy. Okay, so all those are the reason for the blurred vision here, not the trauma here. No?
Yes.
And why impotence?
So to look if patient is having any proximal vessels involvement, proximal artery involvement, like internal iliac or other iliac vessels.
You know any syndrome which is there where
Yes,
the
sir.
patient has got bilateral? Huh?
Larynx syndrome, sir.
Larynx syndrome, yeah. Dr. Abhay, please.
Yes, sir.
What type of trauma do you expect giving rise to both common iliacs being involved?
Maybe trauma to pelvis, blunt abdominal trauma. And
What else?
also penetrating abdominal trauma can also present with this when it is in lower abdomen.
What else? See, when you ask some history where
Yes.
both the common iliacs have been stented, there has to be some
Yes.
pathology and there is no impotence. So it is bilateral common iliac disease. I did not get into the age of the patient. What is the age of the patient?
Yes. 56
What is
years.
the age of how much?
56.
56. So
Yes.
he's in a borderline. He's in a borderline group of getting both common iliacs involved. Can you tell me conditions where both common iliacs
Yes.
without history of trauma, without Leriche syndrome, why should this occur?
So maybe vasculitis.
What type of vasculitis involves both common iliacs without involvement of the aorta? What is Kawasaki disease?
Kawasaki disease is the inflammation of the peripheral.
You don't know. So it is better to say, I don't know. Okay, these questions are high-ended questions, will not be asked in MS examination, but I am getting into it because you are answering very well. So you have to answer why these common iliacs are diseased. What are the factors in the history that are pointing towards bilateral common iliac disease giving rise to peripheral vascular disease? First of all, your diagnosis seems to be peripheral vascular disease when it looks to be central vascular disease. That's apart.
Yes.
So go ahead, explain to me.
Sir, I have kept it peripheral because the patient has presented symptoms because of symptoms in the peripheral lower limb.
Okay, I think we should go to examination and then I will ask you a cross question later. Go ahead.
Okay, sir.
Why did you ask about the blackouts here?
To look if any other system involvement is there, thromboembolic phenomenon is there or not. Retinal artery occlusions or to look for other
What is the
systemic
common cause of the
thromboembolic phenomena.
what is the common cause of the blackout in a patient who has arterial disease?
It is due to
What is
central retinal artery
TIA?
occlusion.
Then we don't have much time.
Transient ischemic attacks.
Yeah. Okay,
Yes.
so that is the reason for the blackouts here.
Yes, sir.
Okay. Yeah. Okay, go to the next slide. What family history you will ask in this patient?
If any similar complaints pertaining to atherosclerosis, like is there or not? Any hyperlipidemic syndromes, dyslipidemia is present or not?
Yeah.
Which can present here, or any ischemic heart disease or not pertaining.
Now, can you tell what are the common risk factors for the arterial disease?
Most commonly is smoking is important.
Yes. Yes.
Sedentary lifestyle,
Yes. Smoking is one.
other smoking, sedentary lifestyle, And other disorders, hyperlipidemia is a risk factor. There are non-modifiable risk factors like gender, male sex, then age, elderly age is also a risk factor. And
Draxted,
Dr.
DRESTED, is a mnemonic for risk factors for peripheral vascular disease. Can you enumerate these 6 things?
Next,
D for hello.
yes, sir.
D
No,
for
no, sir.
I'll
I didn't.
repeat. I'll repeat again. Draxted is the mnemonic for peripheral vascular disease. What does D stand for?
Next, no, sir. I cannot recall it.
Diabetes,
Okay.
है ना?
Diabetes.
Yeah.
R is for Raynaud's phenomena.
Yes.
A for you, since you don't know, go back and read. You will come to
Yes.
know, and it will be very easy for you to answer. Okay?
Yes.
Yeah.
Sir.
Go ahead. Go ahead.
So when you have to answer about this risk factor, so you have to tell about the smoking, diabetes, hypertension, dyslipidemia, and family history, and the age of the patient, and the
Yes.
male sex. है ना? So these are the risk factors for
Yes.
the arterial disease. Okay. I can see Dr. Shri Kumar. Dr. Shri Kumar, you want to ask anything?
No, sir, I'm here. I'm just listening it. Yes, sir.
Yeah. No, he's of your.
Thank you, sir.
Yeah.
Kan-
So
Ganna sir
you
is
can
much
also
more
ask. Yeah.
senior in the specialty, sir. Ganna sir is much more
Okay.
senior in my
Yeah.
specialty.
Okay, Meet, go to the next slide.
Yes, sir.
Okay, tell
And
about
then-
the examination now. Yeah. Okay.
In general examination of the patient, patient is conscious, cooperative, and well related to time, place, and person. I have examined my patient in adequate light, exposure, consent, and in proper position as and when required. Patient is well built and well nourished. He has normal back and spine. On admission vitals, temperature is normal, pulse is 92 per minute in right radial artery, regular with normal force, volume, and tension, no radioradial or radiofemoral delay, and decreased force, volume, and tension in lower limb arteries. Blood pressure is 116 by 70 mmHg, respiratory rate is 20 per minute. Cyanotic changes are present over toes of both lower limbs as seen. No signs of icterus, failure, clubbing, edema, lymphadenopathy. On local examination, on inspection, I have done inspection of both lower limbs and I am describing the right lower limb first. Right lower limb, there is blackening over third toe extending from tip of the base of toe with regular, well-defined margins and clear line of demarcation with the surrounding skin. The toe is dry and shrunken in size, with surrounding skin normal and unable to move the toe. There is loss of hair and Chinese skin seen over distal one third of leg with brittle nails. Purple discoloration present over the tip of second toe surrounding the nail. All other toes are hyperpigmented and thinning of the leg is present. Venous guttering is present. Fuchsic's test shows oscillatory movement. On left lower limb, there is blackening over fourth toe extending from tip to just above the base of the toe with irregular, well-defined margins and clear line of demarcation with the surrounding skin. Normal. The toe is dry and shrunken in size with the surrounding skin normal and unable to move the toe. There is loss of hair and shiny skin is seen over distal one third of leg with brittle nails. Purple discoloration present over the great toe. All other toes are hyperpigmented and thinning of the leg is present. Venous guttering is present. Fuchsic's test shows oscillatory movement. In palpation, I have done palpation of both lower limbs and I am describing the right lower limb first. I have confirmed my inspect findings on palpation. On right lower limb, there is blackening over third toe extending from tip of the base of the toe with irregular, well-defined margins and clear line of demarcation with the surrounding skin. The toe is dry and shrunken in size and hard on palpation. Loss of sensation, no crepitus with surrounding skin normal. Muscle wasting, loss of hair and shiny skin present over the leg, no pitting edema and nails are brittle. Distal one third of the leg appears cold as compared to the proximal. tingling sensation present over distal aspect of foot, no palpable lymph nodes present in inguinal and popliteal region. Left lower limb, there is blackening over fourth toe extending from tip of just above the base of the toe with irregular, well-defined margins and clear line of demarcation with the surrounding skin. The toe is dry and shrunken in size and hard on palpation, loss of sensation, no gravitas, with surrounding skin normal. Muscle wasting, loss of hair and shiny skin present over the leg, no pitting edema and nails up little. Distal one-third of the leg appears cold as compared to the proximal. Tingling sensation present over distal aspect of foot. No palpable lymph nodes present in inguinal and popliteal region. Arterial pulsations on both lower limbs. Dorsalis pedis artery of right lower limb is not palpable, and all other lower limb arteries, femoral artery, popliteal artery, anterior tibial artery, posterior tibial artery are feeble, and dorsalis pedis artery of left lower limb is feeble. Upper limb and head and neck region pulsations are palpable. On systemic examination, respiratory system shows bilateral movement. CVS shows S1, S2 present. On CNS examination, conscious oriented follows verbal command, but abdomen is soft and non-tender. My provisional diagnosis on the basis of clinical history and clinical examination. The provisional diagnosis peripheral arterial disease in bilateral lower limb due to atherosclerosis with gangrene of third toe of right foot and fourth toe of left foot, probably autoelectrolysis, and my differential diagnosis Burgess disease.
Miti, how do you write about the pulsations? You have written feeble, feeble, feeble like that, no? So
Yes,
how
sir.
do you write that?
Sir, we can write in the plus signs that are grading. Double plus signs means the pulsation is palpable. Plus sign means feeble, and minus means there is no pulsation, not palpable.
So rather than writing feeble, you
Yes,
should
sir.
write 1 plus, no?
Yes, sir.
Okay. Or if it is not palpable, you write minus there, no?
Oh, yes, sir.
Okay. Now, how do you test for the temperature in your patient in the limbs? How do you test that?
Sir, we have to first, sir, we have to palpate it by the dorsum of our hand and first expose the patient's both lower limbs for about 2 to 5 minutes so that the external factor is removed, and comparing the limb temperature of the limb with the contralateral limb. The temperature of the contralateral limb should be compared for the temperature. And we can also, if both limbs are involved, then we can compare with the proximal part of the limb.
So from proximal to distal you examine or distal to proximal?
Distal to proximal we examine.
So how will you know that there is a difference in the temperature?
By comparing it with the contralateral limb or proximal. Comparing it.
The patient has a bilateral disease. Then
Yes,
how will
sir.
you know?
By comparing with proximal limb and also upper limbs of the patient.
No, you start from the upper side there, no? Start from the proximal side and go distally. So proximal will be, or the normal temperature will be there probably, and
Yes.
wherever you get, there's a area of coldness is there. That is the site.
Yes.
Okay. Now you have done in your patient the radio-radial and the radio-femoral delay. Why did you do that?
Yes. Sir,
Why did you do that?
look, yes, sir. To look if any aorta involvement is there or not, sir, in this patient. If there is a pathology in aorta, then delay can be present.
Which
in aorta
delay will
region.
be there? If there's aortic involvement is there, which delay will be there?
Radiofemoral delay.
Okay. And if there's a radial delay is there?
Then also it can be present, sir. The aorta, it can also present as radial delay too, sir. Both. If aorta involvement is present or any other thoracic vessels involvement is present, pathology is present, then delay can be present.
Usually if there's subclavian is involved,
Yes,
if on one side the subclavian is involved, then you will get the radio-radial delay. If there's coarctation of the aorta is there, you get the radio-femoral delay.
Femoral delay.
Yeah. Dr. Shiri, you want to ask anything? Okay, go back to your slide. Go back to your slide. Yeah. Now, does your patient has got the dry gangrene or it is the wet gangrene?
It is dry gangrene, sir.
Why do you say it's a dry gangrene?
Sir, because the gangrenous part is shrunken, shriveled, and many the line of demarcation. The line of demarcation is clear, and the surrounding skin is not showing any edematous or any skip lesions or any changes. That's why. Plus, the gangrenous toe is shrunken and mummified. That's why.
You have written, I have examined my patient in adequate light exposure, consent, and in proper position as and when required. Are these all extra things you have written in that, or it is just?
No, sir. It was necessary. That's why.
As and when required, and all these things are probably superfluous type of the things which are there. You tell whether you examine in the patient the supine position, you are examined in the standing position. You have to tell about that.
No, sir. I have not mentioned it specifically.
Okay, go to the next slide.
Yes.
And what is this force and volume in the pulse examination? Go to the last slide. The pulse, you have written
Yes.
with normal force and decreased force.
Yes, sir.
In the same sentence, you are writing radial artery regular with normal force, volume, and tension, no radiofemoral delay, and decreased force. What is that?
Sir, it is the as the volume in the artery.
But same you are writing normal as well as the decreased.
Yes, sir.
Okay,
Because in
go to the next slide. Yeah, go to the next slide. Next slide. Next slide. Okay.
Do we need that first sentence like I have done inspection of both lower limb? What do we need that first sentence? I have done inspection of both lower limbs. Describe the right lower limb first. That's all required?
yes, sir. To know that both the lower limbs were examined, and so I am
That is
starting.
part of it. You have to do it. That's part of an examination. And do we describe that you're taking time, you're killing time on these sentences?
Yes, sir.
So what is the importance of these findings? There is shrinking and unable to move the toe. What does it mean, unable to move the toe? Which movement is affected?
Yes, sir. The gangrenous movement, the flexion,
Which movement is affected? Which
dorsal
movement is
flexion.
affected?
Plantar
Dorsal
flexion.
flexion.
Plantar
Why?
flexion. Sorry, plantar flexion.
It's plantar and
Yes,
dorsal
plantar.
flexion. Which muscle is affected first?
Sorry, sir.
Which muscle is affected first?
Affected, sir. Sir, the
Which muscle?
plantar is affected.
Mostly this is due to compartment syndrome. So muscles which are extension to compartments, they're affected first. The plantar affection mostly by plantar muscles doesn't affect most of the compartment. So when there is compartment pressure is increased due to any ischemia, that is affected first. The dorsiflexion is first affected. And even the
Yes.
complete loss of dorsiflexion is suggestive of irreversible damage also. So always in a ischemic limb, you have to check the dorsiflexion, and that presence is very important to
Yes,
decide
sir.
whether it is vascular and whether it is reversible or not. Okay.
Yeah, Dr.
Yes,
Abhay,
sir.
you want to?
Yeah, I have a question. What is angiosome?
Yes, sir. Sir, angiosomes refer to the specific target block of tissues, including skin, subcutaneous tissues, soft tissue, bones, supplied by a specific source of artery.
Correct. So
These
in
all
your
active.
case,
Yes,
looks to be a central disease, but what is the angiosome that is affected and will decide the future course of action if you try to do any intervention?
sir. In my case, the angiosomes affected are the the plantar arteries. The posterior tibial artery angiosomes are affected.
So how will you go about treating these patients based on angiosomes, deciding amputation or otherwise?
Yes, sir. Sir, if the angiosome is sir, if the angiosome arteries are patent, and we can go for revascularization. Also, after assessing the proximal arteries of the patient.
What revascularization are you thinking about in this patient when there is bilateral disease?
Yes, sir. Only, sir, it is a bypass grafting, sir. Autofemoral bypass grafting, and also other methods available.
This is actually a cardiovascular question.
Autobifemoral.
I don't want to bombard you with all these. What I'm trying to tell you is treat the patient. Okay. There is a
Yes,
central block somewhere which is giving rise to gangrene of
yes,
both the sides. And you have to be very
yes,
careful in deciding. Now, looking at the picture that you have given, both sides look to be dry gangrene. Do you agree with this?
yes, sir.
How will you treat this
Yes,
patient? General surgically,
yes. Sir, I would like to further go run investigations for this patient,
correct?
like going for CT angiography and
How much
But
information will you get towards treatment of this condition in CT angiography?
sir, we have to look for the as this patient is having a stenting already done in common like bitocommunic arteries. I want to look for any restenosis of stent is there or not,
Correct?
and if
from your
any
clinical,
other arteries are affected rather than the iliac arteries also, like femoral, popliteal, or every branches, whole artery supply of the lower limb. We have
from
to
your
check, and
clinical
if it is
evaluation, where can be the lesion?
What is your
from a
diagnosis you have
clinical
made?
evaluation, the lesion can be in aortoiliac region, sir.
Aortic disease. Okay,
And
fine.
you are
Okay.
saying Buerger's disease?
Burgess
Meet
disease.
your, can you
Burgess
get,
disease.
go to your diagnosis?
Yes, sir.
Yeah, go to your diagnosis slide.
Yes, sir.
How can be Buerger's disease? Your both foul pulse are feeble. You said both foul pulse are feeble, and you're saying Buerger's
Yes, sir.
disease. How is it
Sir, as the
possible?
pulse is a
What type of vessels Buerger's is affected?
medium and small vessels affected in Burgess disease.
Yeah. So
But
if a medium vessel is affected, how the femoral pulse is feeble?
yes, sir. So the patient is atherosclerotic. So from the pulsations, I can say that atherosclerosis is the cause. But as a patient is chronic BD smoker, and sir, past history, the patient presented.
No, Chapatala. Do the BD smoking cause atherosclerosis?
No, sir. It is pointing towards Burgess disease, as the
No, no,
patient is
no,
chronic
no.
BD.
Okay, it can be a cause of Buerger's disease. Do it causes atherosclerosis?
Yes, sir.
Smoking?
It is a
Yes.
precipitation. It is one of the factors of this process.
So this because he's a smoker, how can you say it is Buerger's disease only? Those
Burgess
are
disease, it can
possibilities.
be. Yes, sir.
So with this,
You know
this
what
is
is
your patient.
Shenoyer's criteria? Have you heard about the Shenoyer's criteria for Buerger's disease?
Yes, sir. Sinova's is for Burgess disease. When it is in when it is pertaining to it is age is taken into consideration. The small vessels are present, and the patient uh, presents with distal pulsations. Distal involvement.
So you want to change the diagnosis?
Yes, sir.
You want to change the diagnosis?
No, sir, I don't want to change my provisional diagnosis.
Still diagnosis budget is only.
No, sir.
No, I think his
Atherosclerosis.
diagnosis is atherosclerosis, isn't it?
Yes, sir.
What is your first diagnosis? Atherosclerosis, no?
Yes, sir.
Okay, yeah. Okay.
What are the points in favor of atherosclerosis? You have two choices, Burgess and atherosclerosis. What are the points in favor of atherosclerosis?
So the patient is having a involvement of aorta and iliac arteries. The patient's past history and the patient's clinically pulsations are feeble bilaterally, both femoral popliteal and distal pulsations are feeble, which is pointing me towards atherosclerosis.
What
And
about
aggravating risk
aorta?
factor.
What about aorta arthritis?
Yes, sir.
What about aorta arthritis? Aorta arthritis.
Yes, sir. It can be aorta arthritis can be present.
That's
Yes, sir. The involvement. Yes, sir. It can be there.
So you have three choices: Burgess, atherosclerosis, and aorta arthritis. What is the first possibility?
Atherosclerosis, sir.
Atherosclerosis. Okay.
Yes.
Then how do you proceed? As Abhay sir asked, how do you proceed?
No, I am very clear. First, let me ask him whether this is a central disease or a peripheral disease.
Sir, it is a central disease, central arterial disease, but presenting with the symptoms of peripheral limbs.
So, what is your final diagnosis, central or peripheral?
Yes, sir, it should be central arterial disease.
So, what will you treat first? Forget the gangrene that has happened.
Yes, sir.
How will you try and treat bilateral common iliac problem in this patient?
Sir, if there is any occlusion present in bilateral iliac, then we would go for revascularization intervention.
What investigations will you do to look for common iliac bilateral disease that will lead you to try and remove the occlusion in these common iliac problems?
CT angiography.
Good. It shows you block in both common iliac veins. How will you, arteries, how will you go about treating it?
Yes, sir. I would like to go for aorta bifemoral bypass.
Directly?
Revascularization.
Why not stent? Because the patient has been already stented?
Yes, sir. But we can also go for uh, if any stenting pathology is there, we can also improve the current stent, like removing the occlusion
On
of plates
CT
by endovascular
angiography,
intervention.
on CT angiography, how will you decide when will you do ortho common iliac femoral bilateral bypass? These are high level questions. You have already passed the examination, so don't worry about it.
Sir, first we have to uh, look if at how the segments are involved. Like if there are multiple segments involved, or how the grade of aortoiliac disease, whether it is in how extensive the aortoiliac involvement is there, or if there is any distal femoral involvement is also there. But if it is like greater than 5 centimeter segment is present, then I would like to go for bypass rather than endovascular involvement, because there is increased chance of recurrence and failure of procedures in endovascular in such cases. But it is only a spot segment involvement, then we can go for endovascular approach in this patient.
Fair enough. Now, in your opinion, in your patient, you have got gangrene of some toes on both the sides. What will be your consideration towards a major surgery and local treatment?
Yes. The major surgery is that we have discussed right now is the reverse
Correct.
procedure,
Correct. Leave
and
leave leave it aside. Leave
and
it
the
aside.
minor is the dry gangrene. First, I would like to optimize the patient, and then would like to uh, uh, check if the patient is. We can try for auto amputation too, and we can go for digital
You said
laser
auto
amputation.
amputation means what?
Uh, it refers to falling of the gangrenous toe, detaching of the gangrenous toe by itself.
When do you wait for the toe to fall off?
When the pulsations are present, all pulsations are present, this dry gangrene and the proximal involvement beyond gangrene, the skin is normal, the foot is normal,
What
then we
what
can
are
try
the
for
indications? What are the indications where you will surgically intervene in a patient of gangrene of a toe?
when there is a infection,
Correct.
yes, sir, and there is a uh,
So
loss of
when
pulsations, when there it
there
is
is no
lymphatic,
differentiation between dry gangrene and wet gangrene, you like to intervene
yes,
surgically. When you
yes,
intervene surgically, what care will you take that the adjacent toe does not get gangrenous?
uh, when there is no, sorry, sir, I didn't
When
get
will
you.
you take care that the adjacent toe does not become gangrenous when you amputate a wet gangrene of a toe?
When there are no skip lesions in the uh,
When do skip
it is
lesions occur?
when it is in bad when it is having bad gangrene, when the patient is having bad gangrene
No,
in that, and
no.
gas
Wet,
gangrene.
wet gangrenes are sign of embolization. Let us be
Yes, sir.
very clear about it.
Yes, sir.
Your case, if you decide that there is wet gangrene, when will you try and save the other toes? What investigations will you rely on or clinical examination?
It was when there is no signs of inflammation or anything in that gangrene.
No,
The
I
patient
am
is
telling you, your
not diabetic.
patient, dry
Yes,
gangrene, you decided to amputate the toe. What care will you take to see that the other toes are saved?
I would like to offer medical management to increase the vascularity, to improve
How
the
do you
vascularity.
assess vascularity of the adjacent toes?
Right. Basically, pulsation clinically we good for we check pulsations and then we
Very
can plan
good.
for Doppler in this
What
patient.
else? Doppler. What else?
Yes, sir. And then we can go for other duplex scanning.
See, that is what I'm trying to point out to you that you know
Yes,
everything in theory about angiosomes, but when it comes to practical aspects, you are not able to answer to me.
got it, sir.
You got it?
Yes, sir. Yes, sir. I should
Very
refer
good.
angiogram.
So,
Yes,
so you have to combine clinical examination with investigations which help you in determining what to do at what stage and how. You
yes,
understand?
yes, sir.
Yeah, good. You're doing very well. I'm very happy with your. Thank you.
Thank you, sir.
Mintu, you're planning for a disarticulation or amputation of toes. Am I right?
No, sir.
Ah.
Because as the sir in right side DP is not palpable, then I would also take into consideration a higher level amputation in this patient to prevent further
Straight away you go
medical.
for amputation high
No,
level.
sir. After
Hmm.
all investigations, sir. After all investigations, we have to think
What
about it.
investigations did you do?
Doppler, duplex scanning, CT angiography in this
Doppler,
patient.
what are the inference you get, which
Yes,
you
sir.
will decide to amputate or not, and where do you amputate? Doppler,
Yes,
what
sir.
benefit you
Doppler, we
get?
get to know about the uh, uh, velocity of the blood flow of the assess the blood flow
Hmm.
of the arteries.
Will it give an idea about to amputate or not, or where to amputate?
Uh,
We can decide the level of amputation with the Doppler alone. Simple Doppler just to know the velocity.
no, sir.
Then how? How
Yes,
do
sir.
the Doppler help you to decide the level of amputation?
It only shows Doppler shows the patency, like it shows the triphasic waveguide, the
Okay,
patency of
Doppler
the.
shows diffuse disease.
Yes, sir.
Usually they say some diffuse disease from the femoral artery and popliteal artery. So how will you
Yes, sir.
decide where to amputate? Do you have Doppler of this
I
patient?
would like to go for CT angiography for deciding
No,
level.
no. Will the Doppler will give you any help?
Will the Doppler?
Have you
Yes,
heard
sir.
of
It will be helpful to show site of occlusions.
Okay, okay. Have you heard of ABPI?
Yes, sir.
What is
Angle brachial
ABPI?
pressure index.
What is ABPI?
Yes, sir. It is the ABPI index is calculated by the ratio between the angle pressure and the brachial pressure of the patient.
Okay, this patient has an ankle pressure and the PT it is 80 and the DP it is 70. And the right brachial artery it's 120 and the left is 110. How will you calculate it?
ABP is 70, 80.
Can you say the calculation PT by 80 and the DP 70, 110 on the right side, 120 is the left side, brachial.
Yes, sir.
How's the
Ankle
ABPI?
by brachial pressure. It is dividing
Pardon?
that. Ankle pressure by brachial pressure.
The ankle pressure 2, 80 and 70 is there. PT and DP is there. Which one you take? Or you take an average?
Sir, I can for bilateral to assess bilateral limb, sir.
No, you are assessing the right side. Okay, or left side, whatever it is. On the left side, PT is 80 and DP is 70.
Yes, sir.
Then which one is you take? Or you go for an average?
Ankle pressure, brachial pressure. For ABPI, we have to calculate it. And
Pardon? How do you calculate? I don't know the
sir,
value.
ankle pressure is 80, sir.
80.
Yes, sir.
Always
Like
80. It's always 80. Am I right?
no, sir. I didn't exactly get the values for which you are telling, sir.
Okay. Posterior pulse is pressure is 80 and dorsalis pulse is 70. Which one you take us to calculate ABPI? Okay, leave it. There's no time. So you take the highest angle pressure. You take take a PT and DP, whichever is higher, you take it. And on the brachial,
Yes.
which side? For a left
Brachial
foot?
on the same side.
No. Again, is the higher side. Okay. You are looking at the intra-aortic pressure as these then. You cannot measure intra-aortic pressure directly. So you take both angle pressures and take the highest one, which hopefully will surpass the intra-aortic pressure. That's ABPI. And if you calculate the ABPI of this patient at various levels, again, that will help you to decide whether to amputate or not. Okay, fine. Okay, Doppler is done, inconclusive, the multiple also occlusions. Then what will you do? Next is what? Doppler shows diffuse arterial disease with multiple stenosis and occlusions. Then what will you do?
CT angiography, sir.
CT angiogram. What investigation will you do before CT angiogram?
Yes, sir.
What investigation will
I
you
would
do
like to go
before
CT
CT
angiogram.
angiogram? What investigation will you do? What investigation will you do before CT angiogram?
Creatinine.
Pardon? Creatinine. Okay,
Creatinine.
creatinine is 1.8. What will you do?
Then I would like to go for MR angiography in this patient.
MRI angiography is safe for a compromised kidney.
Patients. MRI.
What is delayed gadolinium nephropathy? Have you heard of gadolinium nephropathy?
Yes, sir, it is
Pardon?
medication given.
You're not clear.
It is due to gadolinium. The contrast given
Gadolinium. That is due
can
to an
lead
MRI.
to
MRI. So MRI is not a
failure.
safer option. Only thing is CT will happen today and MRI will happen day after tomorrow. That's the difference. So any other option?
I would like to go. We can
What
also
is-
go for a arteriography in this patient.
Anterior? Have you heard of any other contrast which doesn't affect kidney? Okay, there's some time. I just carbon dioxide angiography. You can use CO2 as a contrast, and CO2
Yes.
angiography is the option for compromised kidney. And 1.8 is not an absolute contraindication. 1.8 also, you can do good dehydration for 48 hours. Again, if you control infection control and give antibiotics to control the infection, you can give NSAID-16, and then you reassess the serum creatinine after 2 days if the patient permits. And if it comes down, you can do CT angiogram with a continuous IV support or IV fluid intake with a good urine output. So 1.8 is not a borderline creatinine is not a absolute contraindication for MRI angio or a carbon CO2 angio. Still, you can do CT angiogram. Okay.
Yes.
CT angio. You have the CT angio of this patient?
No, sir. CT angio is not done for this patient. I have sir Doppler reports and other investigations.
When if I give a CT angiogram film, what all points will you look into?
In CT angiography, I would like to look for the whole arterial anatomy of this patient, aorta, iliac arteries, and other femoral, popliteal, or distal arteries. I would like to see. And if as the patient is having stent, I would like if the stent is in there is restenosis or there is occlusion.
No. CT. How do you read a CT angiogram? You look at the lesion, then.
We have to look for basic arterial anatomy of the patient.
Okay,
if it is
anatomy,
patent or not. In a patient, if there is present or not.
Then there is a 10 centimeter lesion in the femoral artery. Then what all things? It's a site of occlusion femoral artery. Then what else do you look for?
We have to look for collaterals, then distal runoff in this patient.
What's important of distal vessel?
Distal runoff, sir. We have to look for distal runoff in this patient.
What's important to look in distal vessel? Why you are looking at distal vessel? Why you are looking at distal vessel?
Because we are planning for revascularization in this patient. So we have to look for distal runoff.
What's the minimal distal runoff required?
Exactly.
What's the minimal distal runoff required for an intervention?
Minimal distal runoff is required. Sorry, sir.
Okay, it's at least 10 centimeter vessel should be there. Then only you can put a bypass or a stent into it. Okay, fine. Ajay sir or Abhay sir?
Have you done the angiography in this patient?
No, sir. We have planned angiography, but the angiography is not done. Only Doppler and yes.
But in your Doppler, everything is showing the triphasic wave pattern, isn't it?
Yes, sir. The Doppler shows normal in this patient, sir.
So, do you think that is a correct interpretation in this patient, where the patient had a bilateral common iliac disease, stenting has been done, and everything is coming normal?
No, sir. The Doppler is quite doubtful, so I would like to repeat the Doppler, and also would like to go for further investigations.
You know what is task classification? Task classification.
Yes, sir. Task classification is for femoral popliteal disease. Yes, sir. To look for the grade of involvement of the
No, there are different. It is not only femoral popliteal. It can be popliteal also. It can be iliofemoral also. It can be
Yes, sir, like
femoropopliteal also.
infrainguinal or
Yeah. So,
infrainguinal.
what
Yes,
is
sir.
task? What do you understand by that?
Task is also I actually can't recall the whole. It is
It's a
association.
transatlantic,
Yes,
transatlantic
transatlantic
inter-college group. Yeah, transatlantic.
transatlantic society classification.
Right.
Yes. And divided into 4 types.
So, what is the significance of this classification?
Sir, this the task classification, sir, helps to decide on further intervention, further revascularization intervention.
Whether you are going for the open intervention or whether you could do the endovascular intervention.
Open or endovascular intervention, we can plan on that, sir.
Yes. So you can decide based on that. And
Yes,
you have to do DSA can be done. What is DSA?
digital subtraction angiography, sir.
Yeah. So if you are
Yes.
planning for that, one of the angiography you can do the DSA there.
Yes,
Right.
sir.
And
Yes.
CO2 angiography, if the patient's urea creatinine is raised, you can go for the CO2
yes.
angiography. Okay.
Yes, sir.
So what is the plan now? How will you plan for this patient?
Sir, I will plan for CT angiography and then we'll decide on which procedure I want to opt for. And also on the level of amputation if I want to.
Definitely you have to check for the cardiac condition in this patient. Patient had the, you have to control the diabetes of this patient.
Control, yes, sir.
You have to see for all the risk factors which are there, and then only you can. So before you go for the amputation, if it is possible, you should go for the revascularization. Otherwise, your empty stump will never heal. So if it is possible to go for the revascularization before, and then because dry gangrenes can be left over, it may go like auto amputation. Until unless it's a wet gangrene is there where the infection is there, then the things are different. If the dry gangrene is there, you can let it fall by itself. And you have to take care of the pain. What are the various ways to take care of the pain?
First, lifestyle modification, sir. Patient is
patient has come to,
pain,
okay,
pain
that's fine,
exercise, then also medications for
this
medical
patient, how can you exercise this patient? How can you go and exercise the patient? Patient has severe pain. Sir is asking about this patient.
No, sir. Severe pain, I will write for medical management, sir. First.
No, how will you manage the pain? That is what this your patient has severe pain. How will you manage that pain? That's what sir is asking. What are the methods of pain management?
One is, sir,
which medication will you give to relieve the pain?
WHO ladder pattern for that? For any pain, there is a WHO ladder is there.
Yes, sir.
Start with the non-narcotics.
Yes, sir. Like I would like to go for non-narcotic medication.
Yeah, first the non-narcotics, then you may go for the narcotics, then you have to go for all those nerve, imidacloprid and all those pregabalins. But the best pain reliever is the revascularization, if it is possible.
Yes.
Or you have to go for some blocks there, different types of blocks are there. You can go for the blocks there.
Yes.
I think, Dr. Shiri, you want to ask anything or we can close down here? Dr. Kanagawa?
Of the patient.
If you plan to revascularize, what are the options to revascularize?
Endovascular open approach.
How will you decide what type of management is better? Any scale or something?
It is on the segment of blockage. If it is a short segment or long segment, from multiple segments are involved, then we can decide on that.
What is the system? What is the classification system?
For revascularization, like first we go for threatening for limb. If we talk, then we go for
what
glass.
Is TAC? What is task?
Transatlantic Society classification.
What are the criteria for? What are the parameters for task?
There are 4 types. The first one is if only one
No,
third
no,
of the
okay, how will you divide this for the 4? What are the parameters? There are
yes,
3 parameters which you have to use, and depending on that, if the parameters you classify into 4, A, B,
we
C,
have
and
to
D. What are the
we have to check
parameters?
if there is complete total occlusion is there or not.
Hmm.
Yes, sir. Then femoral and popliteal arteries, infrainguinal arteries, and the stenosis is there. How much amount of stenosis is there, and the length of the segment that is involved. If it is
So
less than
segment of
20
vessel,
centimeter,
yeah,
20 centimeter.
segment of, yes, site of vessel, then type of lesion was obstructive or stenotic, then length of the lesion. These are 3
Yes.
parameters by which you divide A, B, C, and D. Okay, fine. So what is the best criteria for best option for task A?
Task A, we can go for endovascular approach. Yes.
Okay, fine. What is LEGS? LEGS.
LEGS legs. Sorry.
Classification system.
No, sir. Legs.
That is to decide whether it's amputation or endovascular or bypass is a better option. Patient's general condition, site of lesion, etc. The categories. Okay.
Yes.
Well, you manage you got an angioplasty of this patient. How do you manage the post or a bypass? What is the post-operative management?
But the post-operative management of bypass.
Bypass. You are the SR in the
Sir,
ward.
I would like the regular follow-up of this patient and would like to go for Doppler studies, clinically assess the patient.
Okay. Then.
Yes, sir. Clinically assess the patient and like every 3 months, first in 3 months, then in 6 months, and then annually, if everything is fine. And in between, you have to check for CT angiography if there is indication. And would like to go for CT angiography on 6 months and then annually to check for patency of the revascularization procedure.
Again, you do CT angiogram to assess the patency or any other method. Clinical evaluation, look at the tilt pulse, ABPI, even a Doppler in the Doppler. Only there is signs of occlusion, then only you have to go for CT angiogram.
Yes,
or
sir.
when if you're planning for a reoperation only, then you have to think about a CT angiogram.
Yes.
Because that's a semi-invasive, you're giving a dye, patient has a lot of condylar complications for
Yes.
this patient. So CT angiogram is not an indication, not an investigation to this for follow-up, unless we are planning for any re-intervention or occlusion or patient has some critical symptoms. Or else you can do
Yes.
clinical and AVPI and Doppler. These are the 3 things required for a post-operative management. Okay, fine.
You have to always tell about the anticoagulant and antiplatelets here. Whenever
Yes,
the
sir.
patient stent is there, initially the patient will be on the anticoagulants and then later on the antiplatelets.
Yes, sir.
Okay. And probably in your patient, both the common iliac stents, they are blocked. And that is why
Yes.
he is developing the gangrene now.
Yes.
Okay. So Dr. Kanagalo is there? Dr. Kanagalo?
Sir, good evening, sir. I'm here, sir.
Yeah,
So,
please.
Amit, do you have any questions or doubts to be clarified?
No, sir. No.
Kirit, sir, your closing comments and then we'll call a close.
No, sir, I would like the examiner to give a closing comment. I said that he is my PG student, so I asked sir, Anna sir and Sri Kumar sir have taken the most of the viva, so better they both sir give some input to him so that he can improvise.
Meet, you are a good student, you have read a lot, but the only thing which I was little worried is that the type of the slides you have made.
Yes, sir.
Okay, so from the next time when you make a slide, take care that you are not all in the capitals, you are in the running fonts. Yeah, okay. So because it is very disturbing to read that.
Yeah, me too.
Okay.
Also,
But otherwise, yeah. Otherwise, you are well prepared. Yeah.
And also take care of the number of lines in each slide document.
That's
It
right.
would look
Yeah,
like
that's right.
paragraph full of slides were seen
That's
in
right. Yeah,
multiple
that's right.
slides.
Yeah, sure.
5-6 lines maximum. That is all is the
6 by
readability of the
6.
slide. Yes, sir.
Okay, 6 by 6 is the
Okay.
rule. 6
Yes, sir.
lines and 6 words in one line. Huh?
Yes, sir.
Amazing.
Right.
Yeah.
And I should
And
put on
avoid
record that we have reached 7 lakh views of our postgraduate clinics. So
okay.
thanks to all
Very
of
good.
us. I
Yes.
think credit goes to every one of you here because every one of you contributed for this platform. And it is thinking aloud. It is 5 years completed. So
Okay.
thanks to one and all. And I wish this keeps going for longer time. And I thank both Dr. Mitt and Dr. Kirit for kindly permitting him to present a case. I also thank Pabita ma'am and Kritika for sharing the first case. So thank you very much. And next week we have a case of
I think we
obstructive jaundice.
must thank Dr. Kanagewal for his almost total efforts. Every effort is made by Dr. Kanagewal. We are only just the supporters there, but he is the
Yes.
main person who is doing everything. Yeah.
It
Sir,
requires a
Yes,
lot of effort and initiation. So
yeah, it's really. I see. Kanagavel is sitting in France, Paris. He is controlling from Paris, maybe the midnight.
Okay.
But he,
sir,
Yeah,
I was
he's taking
he is
all.
going to ask
absolutely
because
committed for that. Yeah.
yes, I was going to
Absolutely
ask that
committed.
only.
Yeah.
Yeah,
Very
Yeah.
good,
Yeah.
very good.
yeah. That's his commitment. He's
sorry, sir.
visiting Eiffel Tower.
My network is very weak today. I'm out in Strasbourg for a meeting. So we'll definitely catch up for the next week, sir. The one case is confirmed already. We have a case of obstructive jaundice. The other case I will shortly confirm, sir.
Done, sir. Done. Thank you.
Okay, congratulations, Kanagavel
Thank
sir.
you, sir. Thank you, Sheikh Umar, sir, for accepting my
Thank you.
last minute request. Thanks for joining today.
Yes, if I am free, I'll be there. No
Thank you,
issues.
sir. Thank you very much, sir.
Okay,
Thank
you,
you,
sir.
thank you, thank you, thank you.
Okay, thank you.
Thank you.
Good night, everyone.
Good night. Good night,
Yes, sir.
Good
everyone.
night, everyone. Good night.